Well, I was sorry to hear Emil couldn't make it, but I did talk with him. He seems like he's doing okay, so that's the important thing. So, and I want to thank Ted for letting me take over and give a talk. So, what I wanted to talk about was really about the OTA and what we've done over the last number of years in promoting excellence in orthopedic trauma care through education, research, and then go through kind of where we were, where we are now, and where we might go in the future. So hopefully we can follow along. And if you have any questions as we go through, feel free. This is a presidential address, kind of updated from 2014. So this is where it all began for the OTA, was Raymond Castillo and Ed Beauville and Mike Chapman. Mike Chapman was my first mentor, along with Tim Bray, and they got together at a Vietnamese restaurant in 1977 and began kind of the whole thing of the OTA and what it was going to do. And they really had pretty minor goals, but very effective ones. They developed a research endowment fund to support orthopedic trauma research, and I can show you where that's gone. But when I started, there were 35 people in the OTA. And we all had to give a paper, because if you didn't give a paper, there would be no meeting. So you didn't know it was a matter of accepting the paper. You just had to give whatever you had going at the time. If it was a start of a paper or an idea, you still give the paper, and they criticize it and make it better and hopefully make your paper better. And then become one of the premier organizations in orthopedic trauma education. It's a big bill, because AO was really big functional at that point in time, and to try and build up the OTA to become a leader in education was a big goal at that particular time. So we've had lots of inspirational developments has happened, provide support for patients to survive trauma. That's the first one. Get them to spend less time in ICU. That's where the John Border lecture came from. He was an ICU specialist and wanted to try and use orthopedic treatment to try and reduce the ICU stay. Leave the hospital earlier, mobilize them more quickly, return to work and school more quickly, and optimize function. Hopefully over the time, develop better tools to rehabilitate patients so they could return to those activities. So lots of myth busters early on in my career. A metal in the wound doesn't cause infection. Anatomic reduction of each fragment is not necessarily essential, and lock nails are required for long bone fractures. They're not bad things. So I remember riding on with people trying to convince different companies to make a lock nail, and they were kicking us out of their companies one after the other. So this is the Edwin G. Beauville Jr. Award, and basically looks at the best paper that has the most impact in orthopedics for that particular year. There's been lots of people who have won the award, and lots of impact papers that have been developed in the OTA that have affected your practice today, you can see. So here in 1998, Bob Ostrom, at that time, retrograde nails are really a thought, not really a practice, and he really outlined it and showed us that retrograde nails can be used effectively for femoral shaft fractures equally well as antegrade nails. Again, in 2000, Rick Buckley came along and with the COTS group, and we decided that we should look at osteolysis fractures. This paper will never be repeated again. It took us for years, about 8 years to finish it. And 450 patients. This is a cartoon I copied. It said this randomized double-blind trial affecting about 20,000 patients was conducted over 10 years. We're not sure why. And that's what we felt like, you know. But fortuitously, the energy was contagious from Rick Buckley. We finished the paper, and I actually have a lecture tomorrow on osteolysis fractures, which shows a lot of the outcomes from that study. Paul Chanetta, of course, looked at syndesmotic injuries, which we have a lab tomorrow in, just to look at how to diagnose it, how to treat it, how to ensure that you get it reduced anatomically. So again, this one, how many people now for a tibia plateau fracture or a pilon fracture get iliac crest bone grafting? Anybody? Nobody. Before 2004, that's what we did. So this paper changed the whole thing. We did it with Tony Russell and a few other people, and it showed that you don't need to get iliac crest bone grafting to treat tibia plateaus or pilon fractures, and that's what we all do today. We don't need that. So it was a terrific turnaround, really. And then we have Mike McKee on my right here that showed treatment of displaced clavicle fractures, mid-shaft, 2 centimeters of shortening. They didn't just treat it closed, they do way better open, and he outlined that to us, and I'm sure many of you have fixed a clavicle fracture in the recent past. So again, randomized treatment of reamed and unreamed nails was what Mo Bonderi cut his teeth on with the SPRINT trial, and he showed us, and we all do it now, that reamed nails are better for tibias, reamed nails are better for femurs, and unreamed nails are not good. They have many more fractures and many more broken implants. So again, nullifier again on my right really helped us mobilize ankle fractures. Before we would treat them in a cast. I remember I had a partner of mine in Moncton, New Brunswick, way back when, and he would keep them in a cast for 12 weeks, non-weight bearing. You know, he thought I was crazy because I would walk them at 6 weeks. Now, nullifier taught us to walk them at 2 weeks, and that's really been a huge advantage for our patients in particular, but to us as well, because we don't have to watch them for 12 weeks. Anyway, the last one, which is more recent, go over just the operative versus non-operative fixation of humeral shaft fractures by Prism, who now is the president of COTS. I passed on the presidency of COTS to Prism, who's running it very well, better than I could, and doing a better job. And she showed that surgery is safer with better outcomes at 6 weeks, 3 months, and 6 months. The outcomes are similar at 1 year if both are healed, but it'll increase a chance of infection, of course. No increased chance of radial nerve palsy, and significantly reduced non-unions with operative fixation. So does this mean you should run out and fix every humeral shaft fracture? No. But what it does mean is if you decide to do that, you're well supported with the literature. So going forward, I think that the future of research is alive and well, but I think it's going to be different. I don't think it's going to be individual surgeons. They're going to do a study and present it. I think it's going to be small groups or large groups competing for funding, and the real driver will not necessarily be clinical significance, but is it cost effective? That's where I think things are going to go in the future. Clinical significance is good, but is it cost effective for me to do that treatment? That's going to be the question. So the OTA has gone to self-management as of 2014. It's up to date at this point in time, and I think it's done a good job to allow us to expand our staff. We used to have 2 or 3 staff. You can see the group here now, and they're there for you to help you with your problems and make sure that things work out for you. At this point in time, we have allowed us, with your help, made webinars, video libraries, and we have an ongoing living textbook to help update yearly to make sure that the information you read online at the OTA is up to date and ready to go. We've also improved our funding, not just from our sponsors, but from our members. And I think that's been a big advantage to show that we think it's important to fund our research and fund our education. Those are what you call money losers to any industry, but they're very important to us, and we spend a lot of time and funds doing it. So this is lifetime donations, over $50,000, the ICON donors that have helped the organization. We have legend donors that are between $25,000 and $50,000, and then donations above $10,000 and below $25,000, so many more of those. So what does that grant funding do? It funds our research. You can see the blue line shows you where the OTA funding does, but it also works as seed funding, so you can go to other areas of funding and improve your funding for your studies. So you can see this has worked to our advantage. By seed funding really good studies, they've gone on to get other funding elsewhere to make their studies even better. So we've helped with education, global outreach, and other OTA initiatives. In publications, has that been worthwhile? Have we funded appropriate research at this point in time? And I think we have. We did a study about 10 years ago that shows our publications are 1.3 times the projects that we funded. So we actually publish more papers than we fund because you can kind of ream off some other papers from the main one. So I think we've got great projects, excellent productive people, and I think it's altering the level 1 treatment that we're providing for our patients and your patients on a daily basis. We also involve ourselves with humanitarian efforts. We partnered with SIGN, which has done a good job for us. They have the humanitarian effort in good hands, and we just help fund it and join with our members to deal with these kind of disasters that you see on a regular basis in third world countries. And by joining with SIGN, we make sure they have the material and the efforts and the colleagues that are there to treat the people that are injured. So I think the future of our leadership is supported by you and by our members, and their individual efforts and those of the OTA staff looks pretty bright and very secure going forward. The OTA staff and Doug Lundy here in 2025 are still doing a great job. They're there for you at any time and willing to take your calls and questions. So I'd like to, without any one of these talks, you can't help but thank the people that put you where you are, and I think the Halifax Orthopedic Group has always allowed me to take off on these courses that I attend and meetings that I attend, and it's always been through their help that I've been able to do this kind of work. I just added a new trauma partner, Kyla Hubner, just arrived actually Tuesday. I haven't met her yet, except for the interviews, and she'll be there to start our trauma program and add to it, and add to the OTA program as well. Secretary Debbie Gaytan and Curtis Giacomontoni, who's our research coordinator, helps us do all these things and make sure that the studies that I used to run with COTS and hopefully still run with COTS will keep on going forward. And of course, my wife Liz, who has supported me and keeps me well grounded. So I'd like to thank you for this opportunity to say a few words. This, in my opinion, is one of the best university trauma courses in the country, and I'm always honored when asked to participate. So thank you very much. Ted, I'll call you back up to say a few words.
So maybe we have a little bit of time. Maybe we could, since the topic is really trauma care and where we've been and where we're going, maybe we could open it up to a few comments as well from the audience and some of our past OTA presidents. Tomorrow we'll also have a section where we're going to try to learn from some of the leadership lessons that the past OTA presidents have had. Mm-hmm. You know, maybe I'd start out too by, I see Dr. McKee there. So he's actually been involved in several different systems, and right now he's moved his practice, was a very, very busy practice from Canada, where he's seen a lot of changes over the years, to the United States, where he's now experiencing a lot of the changes. And I was wondering, Mike, if you could make a comment, and then Ross, you know, you can maybe reflect on some of Mike's thoughts as well. But you know, what do you, in terms of the care of the orthopedic trauma patient over the last 2 decades, 3 decades, what have you seen to be the biggest changes in the different systems that you've been involved in, and where do you think it's going?
I'll put it in here and talk off the thing. So I trained in Toronto, and then I did my fellowship in Boston at Mass General Hospital. Then I came back to be on staff in Toronto from 1993 until 2017. In 2017, I went down to become the chairman of the program of the Department of Orthopedic Surgery in the University of Arizona in Phoenix. So that's kind of the background of my experience with the 2 health systems. When I was in Toronto, one of the good things about the healthcare system was everyone had a healthcare number, and it was basically free. So as long as you could fill out a form and pay a nominal fee, then your health care was for free. So it was unlikely that any kind of catastrophic injury would bankrupt you. And this was a system that was developed back in the 1960s, Medicare essentially. It was based on the British National Health System, which was at the time a fairly well-functioning socialist health system where, you know, as long as you lived in the country, you basically got free health care from the government. And when it was introduced in Canada, it was introduced to the concern and resistance of a lot of physicians who thought that, you know, converting that kind of system took away a lot of freedom, took away a lot of independence, took away a lot of accountability, and that turned out to be true. But you have to remember, in the 60s and 70s, we had a much younger population. They were much healthier, and there was a lot less that we could do for patients medically. Like, we never fixed clavicle fractures, which is great for the patient, but cost the system. Hip replacements were in their infancy, and a lot of the interventions we do now, like these, you know, the TAVRs for aortic problems, that's 60 grand a pop, they didn't exist. And so a much healthier population, a much less expensive Medicare system. As things evolved with time, we found that the population just couldn't be served by the system anymore. And so my last few years in Toronto, when I saw someone in my office for a shoulder replacement, I would say, yeah, you have bad shoulder arthritis, you need a shoulder replacement. This was after they waited to see me for 3 or 4 months at least, maybe longer. And they'd say, great, we'll have the shoulder replacement. I said, that's great, but we'll have to do it in about 2 or 2.5 years. And that was the wait list. And there's no exit for that. The only other outside sources go out of the country, basically. There's no private medicine. There's no way to get that shoulder replacement done any earlier. And I stayed in that system and stuck it out for about 25 years, trying to make it better. I went to focus groups, and I mean, Ross behind me is chuckling because he knows what I'm talking about. I went to focus groups, I went to think tanks, I went to ways of making our replacements more efficient, our length of stay less. I actually invented, people don't know this, I invented outpatient surge for total shoulder replacement about 1998. Because I would come in the morning, I have a list of 4 patients, and the administrator at the front desk would say, Dr. McKee, we have no beds today. So if you want to have your shoulder patients done, they have to go home today. This is like decades, literally, before we started doing this as a a planned event. So I'd go to my patients and say, hey, you waited 2 years to get this shoulder replacement. We can do it today, but you got to go home the same day. I think it's safe to do. I wouldn't recommend doing it. You know, this is someone who's got some home support, fairly healthy, as long as things go well, et cetera. And then we would send them home the same day. That's how we started doing it, because we had no resource, no hospital beds, and everything was very strictly and tightly controlled. And I kept thinking to myself that it's got to get better at some point. Things have to get better. And they basically never did. And so now there's still huge problems with wait lists, and it's good care when you get it, but just it's rationed care. And for what we do, especially on the elective side of things, it's a big problem. On the trauma side in Canada, it's better. If you need something acutely, you get it done acutely, although you may lie around in hospital for 3 or 4 days with your ankle fracture or whatever before you get time in the OR to get fixed, basically. So I think that's probably the main frustration with that system, which continues to this day, is that it's just not enough money and beds and OR time for the population and the sickness of the population we have now. If you want to increase that and make it better for the people, you have a couple of choices. One is to make the system more efficient. And I don't know about other parts of it, but as far as orthopedics goes in Toronto, we could not possibly be more efficient than we were in terms of minimizing OR time, minimizing cost in the OR, getting, kind of contracts to drop the price down as much as possible. So that's not really an option. Second thing is jack up taxes, so you get more money to pay for things. Canada already has one of the highest tax rates in the free world, so I don't think that's a very palatable option for most people. Or you simply ration care, and that's more or less what's happened, I think, without getting too political about it. And it's still happening. And so I see people, I regularly operate, Canadians come down from Alberta and British Columbia or Saskatchewan who wait, rather than wait 2 or 3 years, they come down and have their operation done for a shoulder replacement in outpatient surgery and go back home and get looked after by the local person with pretty good, it's been a pretty successful program, and they're very happy with it going forward. So that's kind of the situation we're in now. Where we are now in the States, when I have a trauma patient come in, they get immediate care. If they have no health insurance, it doesn't make any difference to us whatsoever. The person's going to get their open tibia fracture fixed and nailed that day. The resources are better. I don't fix hip fractures at midnight anymore. I don't fix ankle fractures at 2 o'clock in the morning because I have access to the OR during the day, where it's better for me, it's better for the patient, it's better for the hospital as well. And so resource is much, much better, and they want you to build a program there, whereas in my old practice, it was always revenue neutral. You're allowed to do 100 shoulder replacements a year. We know you're maxed out, so hire someone else, but the 2 of you can only do 100 shoulder replacements a year. That's the limiting factor here, and that was something I heard over and over again. The downside, I think, to the American system, of course, is cost. It's over-administered. The insurance companies, I think, I don't know how to put it properly, but they have the upper hand right now. Like, United Healthcare made $24 billion in profit, not just in revenue, but profit last year. We have continued denials. All this, even a pre-approval isn't necessarily the fact you're going to get paid for it, et cetera. So that seems to be a big issue. And the balance that should be there, I think, has been lost a bit. And I think that's going to come to the forefront in the next little while. And sometimes we see patients who have no insurance, who have a fracture electively, who simply can't afford to get it fixed. And I've seen that a couple times. That's absolutely the downside of the system. So I think it could be run much more efficiently than it is being run right now. And there are some major issues with people being financially crippled by medical problems that really aren't their fault, and they end up paying for it. So I hope that gives a fairly balanced picture of what I've seen in my career. My own personal feeling is that and this is utterly simplistic for any economist out there, but healthcare should be like flying an airplane. The government should provide you with a good, safe airplane and a competent crew, and everyone gets an economy class ticket. If you want to upgrade on your own dime to business class, you should feel free to do so. If you want to have your hip replacement done at St. Michael's Hospital on a Saturday with an anesthetist and nurse who want to be paid, and I'm going to do it for you, you're going to pay for prosthesis, there should be no issue with that whatsoever. You get your hip done, you get out of the wait list, everyone else moves up a bit. I think that'd be a very reasonable system. But for political reasons, jumping the line and rich people getting care quicker, it's never been a popular option back in Canada. So that's really my simplistic view of the whole thing, and I'd be happy to hear about any questions.
So I actually have a...
With one, pardon me, with one exception, Quebec. So, do you want me to tell a story? Is this a bit of an... En français? C'est bon, monsieur? So there's an exception to one thing. There was a Quebec lawyer named Shaouli who had hip arthritis. And he went on the wait list and waited forever to get his hip replacement done. And eventually his case went, he sued the provincial government saying it's unethical and unconstitutional to put a monopoly on a service and then fail to provide that service in a timely fashion. And his court case went all the way through to the Supreme Court of Canada, and eventually the Supreme Court said, yes, you're right, hip replacements, you should be able to pay for them on an elective basis, but only hip replacements and only in Quebec. So it's a very narrow niche right now that's available. So, may I paraphrase that?
Okay, let me just explain how Michael's kaleidoscope of reality might not be true. So I am a Canadian. I was a representative of the Canadian Orthopedic Association. I was president in 2013, so I sort of know the inner workings. My wife works as a physician on the government side as well. So in Quebec, I have no wait list. It's under 6 months. Almost everyone has no wait list. We have a rampant private and public system, which seems to work now. So you can get your total hip done next week if you want. You get your total shoulder done in 2 months. So you can sort of select that. You will pay extra if you want to jump the list, but it's made my list shorter. I don't do private. I just do public. My list is 3 months. And I have no problem getting through my cases in a timely fashion. We are
agree.
not.
The one province, so for one
You have
province.
to get operated on by me. I knew you were going to say that.
Plus, you have to have him as your doctor. C'est dommage. So the thing is that is absolutely true, but it's one province, and there's still significant problems everywhere else. I mean, Ross?
No, ours is as Mike suggested. So the acute care is great. You can get in wherever you want. And we have great wait lists. We operate during the day. We don't operate at night. It's a very good lifestyle for a trauma surgeon, but elective surgeon, you're waiting a year plus to get your total hip or total knee or total shoulder.
The one other thing I had to rebut, though, is that I don't operate it after midnight. I have trauma room every day, so I can do all my cases during the day. So it is sort of like the American system. We have a different pay scheme. Orthopedic surgeons are not at the top of the heap. We're number 23. Our pediatricians are paid the best in the world. You have no problem having your kids have adequate care at any time. That's the way we've done things differently a little bit in Canada, and I seem to do okay with it. But Michael's doing well with the way he's come down to the States and done it his way too. So it's a little different in every province. So
there's actually an article here saying the Quebec waitlist has doubled in the last 4 years.
We're calling bullshit. Bullshit.
So our wait list.
A fact check.
So I've been told that my wait list story was bullshit.
Fact check.
So it is, because we can never fact check what McKee said. So the point is our wait list is totally open. That's why that data can come out. And my wait list might have went from 2 months to 4 months. I don't know.
Prism, thoughts from Western Canada, thoughts?
Quebec. So we have a number of private surgery centers. And that's really offloaded a wait list. It's a little more in its infancy, so we're a bit further behind as far as the development. One barrier that I would like to highlight, because I do think it's a bit of a challenge, is cross-provincial care. So ironically, our privatization is working very well in Alberta, but it's working well if you're a patient from the neighboring provinces to come and get your surgery. So I feel like that's an area that we need to kind of improve and work on a little bit. We're serving those in Quebec, and Albertans are going to Quebec. So that's something we can fix, I think.
Let me just ask this. So if I'm an Alberta patient Can I go to an Alberta doctor and get my hip replacement done privately? Yes or no?
The answer is yes.
In
However,
Alberta?
correct. However, we are, and how that prioritization is happening, I'm a trauma surgeon. I am not an elective private surgeon in any way either. But out of province patients are prioritized at this time.
Out of province
Yes.
patients,
Yeah.
Thoughts or comments from the audience? This is a good discussion.
Yeah, I just have a couple comments.
Yeah, go ahead.
Yeah, I'm married to a Canadian, so.
You're almost Canadian, Tim.
I'm almost
Canadian.
there.
My condolences, yes.
I'm kind of half, so I'm one of those
And he
guys.
trained at Canadian,
I
which
can
makes
wear
it
the
even
hat
worse.
both ways, so anyway, but I wanted to just, I'm going to change the topic just a little bit. I just want to talk about Ross.
Yeah.
So, all right.
I'll sit down.
I think I'm the most senior traumatologist around here now. I actually knew Dr. Beauville. I actually know Dr. Chapman very well. Many of the traumatologists in this room I have worked with or taught or spent some time with. And I think that the two characteristics of the traumatologists who come out of this environment are, number one, they are all really good surgeons. I mean, I would not hesitate at all to have any of the people that have trained in this environment operate on me or my family. So I'm really proud to have been taught by the best and trained by the best and been able to share that. And Dr. Leighton is certainly one of those people. He's a great surgeon, has a great personality. I haven't gotten to go sailing with him, but I'm a sailor, so I think maybe that would be kind of fun. And the other thing is that there's always been a philosophy around here is that you're not taught, you're not born with the skill set that we all have. Somebody has to teach you. And I think that everybody who's been in this environment really takes teaching on very seriously. And Ross has been one of those people as well. Ross is an incredible teacher. He has the skill set, he has the time, he has the patience. And I think that that's just another one of those great characteristics. So I think we're all blessed to have had Ross as our president. It's always fun to be around him, and I hope I have a few more years to enjoy him as well. So anyway, please raise your glass and give Ross a round of applause.
Overly kind, overly kind. Thank you. Thanks, Tim.
So Tim, just before you go, just
We're gonna get
do
you
have you do have one of the things that you've been teaching us, and that you will teach even next year. You had a course last year was in the same topic. We're talking about the business of orthopedics,
Yeah.
the one that sort of Mike had brought up, and so we got a perspective on the Canadian system, and you've seen it. Being that the finance part of it is so integral to the care that's provided. So in the city, for example, prior to the Affordable Care Act, half the people in the city didn't have insurance.
Right.
So those people being able to access care couldn't. And Mike had mentioned the idea of having the business, the economy class seat, and you can upgrade it if you want. That's a little bit what the Affordable Care Act was intended to do, political views aside, and it did that, at least in the city and county. You've seen this happen. What do you view as how this whole thing is going to evolve in the States? And just taking Mike's observations and moving them at least through your lens.
Yeah. Well, as you know, I was with the University of California for 8 years with Dr. Chapman at UC Davis before I left. And to be quite frank, I just became so frustrated with the administration of the university and of the department. It's just, God, I just thought that we could do better. And I wanted to put my billings out to a third-party billing service and just to compare what the billing services would be from my practice compared to everybody else's. And nobody had the initiative to want to do that. And so I left and joined a private practice in Reno, Nevada, in northern Nevada. And so my career over the past 35 years now has all been in private medicine. how to grow a private practice, how to work with ancillaries, how to work the capitalistic system, basically. And finally, these last couple of years, our ancillary income surpassed our practice income. And so I think the bottom line is that reimbursement is going to continue to go down. California has 1.6 million illegal aliens that are part of Medi-Cal. It's under budget by $2 billion. And so the idea that Medi-Cal rates are going to increase over the next 10 years the chance of that is zero. They will continue to go down. Medicare is America's insurance policy. I mean, that's 65 million Americans have Medicare. And our current leadership is in disarray, maybe I could say, or it's changing. And, everything is being cut. HHS, Dr. Oz cut 10,000 jobs, and saved $1.8 billion. And we don't know if that's going to decrease our tax rate, if it's going to be passed on for patient care. Not really sure about what's going on with any of that quite yet. But I think Medi-Cal rates are going to stay down for the people in California, and I think reimbursement for Medicare will probably continue to go down. There's a bill out there, I think it's HR 897. I went to the BOQ meeting this year, and your Board of Counselor representatives are working aggressively to try to fight the decrease in the reimbursement for Medicare and possibly get an increase over the next couple of years. So that's kind of my take on Medi-Cal for California and Medicare for our insured that are 65 or older. I think private practice, probably like Mike, I think the longevity of large private practice groups is questionable. I always say that I think we're one vote away from losing our business. And I think at some point in time, there may be more federal involvement or control over the private practice of medicine. I felt that I had an opportunity to kind of develop this practice and participate in its design and development. I think we do a pretty good job. I think outpatient surgery, like Mike suggested, patient outcomes are better, it's cheaper, patient satisfaction is higher. I think the world moving to the ASC is really a good thing for orthopedics, and hopefully we'll be able to experience some cost savings because of that. So anyway, that's kind of my vision, but yeah, we do.
There's some spine practices now that don't take
Yeah,
patients.
yeah, right. Do we take Medicare patients? And the answer is yes. They probably don't get the first slots, in the outpatient clinic schedule, and they may have to wait a while. But I think, when you have underinsured in your community and your kids go to school with a family that doesn't are underinsured, it's pretty hard to send those people away. So I think there's more of a community spirit across North America and some of these smaller towns that we may not have in the bigger cities.
But private practice spine groups, so they can't make a living with Medicare patients. They're stopping to see them in some situations.
I think that's true. Yeah, Mike said that some of the spine practices are not seeing Medicare patients. That hasn't been our experience. Yeah. So anyway, that's kind of, I didn't want to take anything away from Ross. Ross.
Ross started this conversation, and so now he's got to end it. But Tim, thank you for doing that. And so Ross, I'll give you, if I were going to summarize some of the topics that you covered, is basically, we started with the OTA and the idea of mission of doing trauma. And, a lot of it happens to be tied to these other factors, which are societal, environmental, which ultimately create financial pressures on us and what we can do and can't. Unfortunately, a lot of our trauma patients, they don't elect to have trauma. They may have trauma regardless of what their insurance status is, and usually the ones that can least afford it are the ones getting into the trauma. And we just have different systems that are dealing with this. And, obviously we're going to have to continue to struggle with this. And so last word to you.
Well, Dave Alexander once told me the last dollar to be spent in orthopedics would be spent in orthopedic trauma because you have to treat them. And I think that's the case with us. No matter what you do, when the patient gets injured, you got to take care of them, and I think that's what you guys all do every day. So thank you very much.
Great, thank you.